Good afternoon. This is the webinar, the fourth webinar series for Healthcare Transition and Title V Care Coordination Initiative webinar series. We're glad you're all with us today. And we're lucky to have Mary Ciccarelli from Indiana University School of Medicine joining us today as well. I'm Dr. Patience White from Got Transition. Next slide. We have no disclosures, as you can see here. Next slide. Just to remind us a little bit about the goals of this webinar series: to support state Title V implementation and measurement of healthcare transition and care coordination programs, guide care coordination improvements, and share promising practices from state Title V supported care coordination programs. Next slide. So today we're going to be talking in webinar number 4 about integration into adult care. And we really want to think about supporting the development of a healthcare transition policy and a welcome and FAQs information of the adult practices that you're identifying that may take on the young adults that you're currently caring for. And ideally, once you have this information, you can share it with pediatric practices so they can make some choices about who they're going to be following up with. We also want to be thinking about facilitating that initial appointment to the adult clinician, and what includes confirmation that they received that transfer package that you've been talking about, and covering the youth during this bridge time, which we'll be talking about. And then we're going to hear from the Indiana Title V example of supporting adult clinicians and young adults who are transferring and linking to adult disability resources. Next slide. So these are the handouts that will be available after this. You can see that we're going to be giving you an example of a welcome and FAQ information and the practice resource integrating young adults with intellectual disabilities and developmental disabilities into your practice. Tips for the adult healthcare provider. And Indiana CYACC is kindly offering the resources that you'll see. She'll talk about the activated patient, the visit summary action plan template, and adult practice support, two resources for the PCP, caring for adults around adherence, and the activated patient. Next slide, please. So just to recap, and for those that may not have been able to come to the prior 3 webinars, on the first webinar, we really talked a little bit about the clinical foundations around the AAP, AFP, ACP clinical report and the 6 core elements. We heard about the performance measurement options, and then the Title V care coordination baseline results from the current assessment. We talked a little bit about starting a healthcare transition pilot using quality improvement and the core element processes, and writing an aim statement and trying to put together this pilot. Next slide. On webinar number 2, we reviewed some of the 6 core elements, and particularly the transition policy, tracking, readiness assessment, and planning, and then talked about options for customizing these tools and what the American College of Physicians has done around some of the subspecialty tools that are available. And we heard about DC's Parent Navigator program at Children's National Health System. Next. On webinar number 3, we identified ways for thinking about finding those adult primary care and specialty providers, thinking about having an adult model of care and the Got Transition resources around that, even though they may still be in the pediatric environment. Understanding the contents of the transfer package. What are you going to put together to send to that adult provider? And then identify ways to communicate with and support adult practices, this care coordination support. And you heard from Kentucky and Maryland care coordination programs about how they plan and support transfer to adult health care. Next slide. So now today we're going to be thinking once again an overview of the 6 core elements and sort of the roles of clinicians. You're seeing a busy slide in front of you, but really this is just putting both the pediatric and adult provider activities under each of the core elements. Both have something to do when they're taking care of a young person with medical complexity or not, just in general, thinking about how to take care of young adults. So we've talked about the policy, tracking and monitoring, and transition readiness and planning on the pediatric side in that top part of this grid. Today, we're going to be thinking about that moment of the transfer of care, that sort of moment where they're really ready to leave the pediatric provider and going to go to an adult provider. And then you look down, and today we're going to talk about two components that you could encourage the adult provider to do as they're getting ready to take care of the young person that you have under your care. One is to have a transition care policy, really to create that with young adults. And the other part is that welcome and FAQ information. This is really very helpful to get people aware of what is offered at that adult practice. So next slide. So this is sort of visualizing that bridge process, because it isn't that they leave the pediatric practice and then the next day they're sitting in the adult practice. The problem is usually a time in between, and a lot has to be done and checked on during that time. So you can see they're preparing for that pediatric visit, the last one. Then there's that bridge time. We'll talk about what people need to be thinking about during that time. And then that first adult visit, how to integrate it into adult care. Next slide, please. So now we're back at that left part of that sort of schema that we had, and thinking about, we've talked a lot about preparing young adults for transfer, but I think it's important to also add some things to this. Now, you obviously want to identify the adult provider, and ideally you may have 2 or 3 potential, and if you have those welcome letters, then the young person and the family feels like they have some choices here. It may be different where they're located, how they write their welcome letters, and so forth. You want to also think about discussing the role the primary care clinician plays in the adult care system, which is often different than is played in the pediatric system. Often, pediatric subspecialists are really the primary care provider, and the primary care provider in the pediatric system is really playing a secondary role. In the adult healthcare system, this is often reversed, because often they're not subspecialists that directly end up being the same as what that pediatric subspecialist was, and they play a bigger role in thinking about how to care for the young person as they age. Remember, they're in the pediatric system maybe 20 years, maybe up to 25 or 30, but they're in the adult system potentially for another 50 years. So they need to be thinking about the healthcare system and what has to be done as the person ages. Also think about giving that young adult that information to actually call the adult clinician's office. You might make it a joint call. In some of our integrated systems, they actually do a FaceTime call with a nurse in the adult office, so they get a sense of who they might see when they come in. Then you want to make sure that transfer packet, we've talked a lot about that, but you want to be sure, you want to help the adult provider engage that young adult. And how can you do that? You really could help them by saying something about that young adult that's non-medical, that would really engage them. So for instance, if the young person does really well at drawing or music or something, then you can pass that information on to the adult provider. There's nothing better as an adult provider to have that information, be able to walk in the room and say to that young person, gee, I've heard from Dr. So-and-so and your care coordinator, and I'm so excited that you're so good at whatever it is that young person has decided to share. It certainly helps engage them. They're more interested in coming back for another visit. They feel they're a person in this new office, which I think is important. Also, as a care coordinator and the pediatric provider, it's very helpful to focus the adult provider. After all, they're picking up a lot of information very quickly on something that really has to be done in that first visit. If you're really leaving something to be checked, has to be looked at in particular, giving that guidance is often very helpful. And consider if you have a condition fact sheet, if this is an unusual condition that an adult provider has not seen before. And the other key thing here is so the family and the youth don't feel left in the lurch, that the pediatric provider and you as the care coordinator are going to assure this young adult and family that if there's something they need between the time they've left that last pediatric visit and are first seen by the adult visit, they will be covered by the pediatric or care coordinator. I think that a lot of complaints of families are that they say goodbye to their pediatrician and they have a wait of maybe 3 months or so before they're seeing the adult provider, and all of a sudden they run out of their medications. They call back to the pediatrician who says, oh, we're not caring for you anymore. They call the adult provider who says, I haven't seen you yet. So you don't want to leave them in that confusing setting when you're in this bridge time. Next slide, please. So here's this time where they have left and are about to go to their adult provider. You'd ideally hope that all the information, that there's been a letter or some kind of information that's been passed between the two practices. You as a care coordinator or the pediatric office should remind the young adult, if you didn't set that appointment when they were there in the pediatric office, that they need to do this. They also want to be sure that they know, once again, that they're covered until they see that adult office, and be sure that the adult office knows this as well. I think ideally that adult office should call that young adult to schedule that first appointment and identify needs for accommodations, but it may have been already done in that pediatric setting. You also want to see if that young person made it to that first appointment. I think it's important to follow up and be sure that they made it to that appointment. And if not, why not? The pediatric and the care coordinator actually know this family and are more likely to get them to actually go to the adult appointment. And if you can, getting some kind of follow-up, obtaining feedback on the total process that's gone on before this. And usually you should ask this after they've had their first adult clinician appointment. Next slide. Now, what would be in this adult practice healthcare transition policy or welcome letter? And what you want to have, and think about this just yourself, if you were going to a new doctor, you'd love to have some kind of welcoming language. And that language really is going to state that they do want to see young adults. That's something that our young adult advisory group is very clear about, that it'd be nice that these people really are interested in seeing young adults. And that this policy and welcome letter has been reviewed by young adults, and that it does explain, again, clearly the adult model of care, what the expectations are, as long as they don't have other legal documents that would change the fact that the young person now is in charge of their care completely. Reminding them of that privacy and consent information. And obviously the medical information needs to be in the adult clinician's office before that first appointment so they have a chance. And you can look at some of these at our website. Next slide, please. So here are some things that came up as we were talking to young adults. You can use some of this language at our practice. You have the right to be obviously treated in a caring way, make your own decisions. Talk with your healthcare provider alone. We hope that's already happened on the pediatric side. Have things explained in a way that you can understand, and that you have access to your medical information. How does that work? Is there a My Chart? Is there an electronic way that they can see their medical information? And then really reminding them again of their responsibilities, keeping appointments and canceling them in advance. Trying to be sure you're ready to tell them about your current symptoms and health history. You want to really think about how they followed their treatment plan. You want to really develop that with your healthcare provider. You want that they should be asking questions about their care, and knowing what their insurance covers broadly. Nobody knows the absolute detail, but knowing a little bit about your insurance, I think, is part of the responsibility. Next slide, please. Now, this is some of the questions that young adults have put together that they're interested in having some answers to. And you're just seeing the questions here. Ideally, what would happen, you'd have this question, and then you'd have the answer typed in there by the adult practice. Really, what are the services does the practice provide, so that they are well aware that do they provide sexual health, mental health, behavioral health? Is that available? What are the wellness programs? Are the services confidential? That's asked over and over again. Young adults are very interested in that. Where is this office located? A map is often helpful, and what's the nearest public transportation? What providers are available? Some of these welcome letters actually have a picture of the adult provider who they would be seeing. That's usually very helpful. What are the office hours? Are there walk-in options? Are there after call-in options? And how do I schedule, reschedule, or cancel an appointment? Is this done online? What insurance is accepted? Is there a general sense of what the visits may cost? That's often hard because a lot of people don't necessarily know, so sometimes that's not included. What should I bring to my first appointment? This is really prompting people to bring the right information. And what are the resources that are available to help me learn about wellness and self-care? Are there nutrition, fitness classes, support groups, other things that are in the community? So these are community resources. So these are the questions that young adults were interested in having the answer to before they go to an office or while they're there, and can be gone over by the adult provider with the new young adult in that first visit. Next slide. I'm really excited now. We'll turn this over to Shirley Payne, who will be introducing Mary Ciccarelli. Shirley?
Hi, yes, can you hear me okay? Hello, can you hear me okay?
Yes, Shirley, we can hear you.
Okay, sorry. I was like, wait a minute. Hello, everyone. It's a pleasure joining you today on this webinar, and really it's actually an honor for me to be able to introduce Dr. Mary Ciccarelli. I tell people all the time, she's one of the greatest people that I know, and I would argue up and down that she's one of the best people on the face of this planet. Just the care that she takes, especially when it comes to serving and helping individuals with special needs and medical complexities. And so she's done a lot of work, and it's just an honor to be able to work with her every day. And so just a little bit about Dr. Ciccarelli. So she is a med peds doctor here in our Indianapolis area. Now, she is affiliated with a few hospitals, and Dr. Ciccarelli, you can correct me if I'm wrong, but is within our Eskenazi Health Hospital, as well as the Indiana University Health Hospital as well. And so she received her medical degree from Albany Medical College, and she's been in practice more than 20 years. One of the great things that she had conceptualized and really brought to life was the Kayak, which is the Center for Youth and Adults with Conditions of Childhood, which is a transition to adulthood program for individuals, youth and adults with special needs. And so for the State Department of Health perspective and a Title V perspective, we have been, maybe funding this program a little over 10 years now. And the great thing is that as we evolve for Title V, and even just recently, and we've had to go through the transformation 3.0 with Title V, the program has evolved as well. And one of the pieces that has been so beneficial that Dr. Ciccarelli and her team have really worked through and tried to help figure out is really that transfer of patients. And so as we're seeing young adults and as we're seeing children, how are we ensuring that we are doing the handoff and that we're not always feeling like we're having to operate in crisis mode? You know, Dr. Ciccarelli and I talk about that a lot, is sometimes, you know, the patients that do present in the clinic really just have a lot of other things going on. But before her clinic can assist them with those transition needs, what else can we do to knock out those crisis pieces so we can focus on your future? And one of the pieces within that, and it's just a multidisciplinary team, which Dr. Ciccarelli is going to go through a little bit more specifically of what their team is made up of. But between the social workers there, even the students and the doctors, really working to enhance the life of individuals. And so as part of this transfer, and with the portable health summaries that they provide to patients, it really has been a transforming practice for young adults with special needs. And another great piece that, you know, we've been very proud to support with Title V as well is this idea, this thought around the self-management and self-care. And Dr. Ciccarelli's team has done that very well. They were supporting the program of the Be Your Own Boss program and implementing that. I was fortunate enough to be able to serve and help with the focus groups with young adults with this particular program, but also being able to recreate our state Title V transition book. Kayak really took ownership of that and really developed it into something very nice. And one of our goals with Title V moving forward is to be able to make that available, kind of an interactive environment online for individuals. And, you know, we'd be happy to share, you know, a link to that so everyone can see that resource. But we've been approached by a few different states, if I'm not mistaken, just about adopting pieces of the book that Dr. Ciccarelli and her team helped to develop and put together. And this book has also been presented to other organizations that assist with individuals with special needs and medical complexities. In particular, Dr. Ciccarelli's team did a lot of work with the Down syndrome here in Indiana, at focusing around that self-care, self-management piece as well. And then a third piece that we really have been very supportive on is really helping with this concept of how can Title V be more involved in educating the new learners. And so in Indiana, we have 8 residency programs in the state around with the IU School of Medicine, which is one of the largest medical schools in the country. And Dr. Ciccarelli has graciously allowed students of all disciplines, but particularly medical students, to come in her clinic and experience what it is like to do a visit and do an evaluation with an individual with special needs. Because we're just recognizing that, you know, as we go along and the future goes along, we need more doctors to be able to come in and want to be part of family medicine and pediatrics, and not necessarily just moving on to specialty care. So it's just been a pleasure to work with her, watch how her clinic has grown. I keep telling her she can't retire just yet. I need her for at least 5 more years to hang on for me. But the last piece that I just like to mention about Dr. Ciccarelli, one of her greatest accomplishments as of late, she became a grandmother to little Miss Regina, aka Reggie. And so she's so proud of her. And she's in New York, so we figure she's about to get a lot of airline miles back and forth to New York. So it is a pleasure again to introduce you all to Dr. Mary Ciccarelli.
Next slide. Thank you very, very much, Shirley, for that laudatory introduction. It's been our pleasure in Kayak to work together with the State Department of Health Title V program and deliver some work in the transition of care. Next slide. So we call our center Kayak, even though phonetically that might not be accurate, but it helps people remember who we are. We have a transdisciplinary team of social workers, nurses, physicians, and parent and youth representatives. And our focus is to improve the care of youth with special health care needs as they transition into adult services. We do that by offering consultation and care coordination for youth ages 11 to 22 who have any chronic health condition and are encountering some difficulty in meeting their transition need. A critical piece of this is that we involve education that grows the system, not just the individual service delivery to the youth and family. Our School of Medicine, as Shirley mentioned, is the largest in the country, and we have primary care trainees across all the classical fields of primary care who come and work with us in Kayak to have experiences in thinking about this transition period, in thinking about working specifically with people with significant disabilities. Our funding is primarily through Title V, as well as through the Department of Pediatrics and our county health system, Eskenazi Health. Next slide. This slide is not meant to be looked at in detail, but kind of to just get this visual of what we do. To improve transition, we want to do direct service delivery, but also have trainees and primary care docs involved in education processes. And so the two groups of yellow arrows show that learners from across the medical school and residency primary care residency training programs come with us to actual face-to-face visits with patients that are transdisciplinary, usually an hour and a half to 2 hours long, where nurses, social workers, and physicians all do an assessment in a transdisciplinary fashion that informs the transition plan that we generate. And then the other key point for education is after we've had the visit, the team meeting, we go on to do care coordination with lots of co-management and communication back and forth, either to the existing pediatric primary care practice or introductorily to the new adult practice. And for the purpose of today's webinar, we're thinking specifically about that transition to and transfer of care to the adult primary care provider. Next slide, please. This is what we call our bucket list. I'm not sure how we got that name, quite honestly. It's probably that movie came out the year we created the list. But we go through these different points of assessment when we prepare a transition plan for somebody who has complicated transition needs, so that we make sure we attend to all of the important issues. We use that model of the bridge to transition that we've already been talking about, where we hope that the pediatric care system has done some work on developing self-management skills, in particular, as Dr. White mentioned, introducing time alone for the youth to be speaking directly with their provider. And now we're talking about, as we've done the transfer of care, what happens in the receiving side on the adult care side. And the big learning point there for our internal medicine, med-peds, family medicine residents is to begin to both recognize when these patients come to you that they are different than your garden variety 50-year-old in your adult practice who already knows how to, quote, play the game of healthcare, close quote, meaning they know the whole interaction process and the autonomous model of adult care. These young adults who are arriving at practices aren't as familiar with that. And so we think about and introduce the concept of creating scaffolding during this integration period so that the young adult has time to acclimate, acculturate into the different culture of adult medicine. Of course, as that's happening, the family is stepping back to allow the youth to step up. And that's another critical piece of how the scaffolding changes at the integration into adult care. Next slide, please. So for Kayak, we've learned that these 4 categories of types of healthcare needs help us predict or inform us of how to approach the transition services we prepare for people as we're integrating them into adult care. Individuals who have a chronic illness like inflammatory bowel disease, like sickle cell anemia, like cystic fibrosis, in addition to needing a primary care doc, healthcare financing, and to know when they're the person signing their own consents for care, they also need to know how to manage their treatment plan, who else is on their healthcare team, and how to help them through that very vulnerable phase of young adult non-adherence. People who have physical disabilities need, in addition to the things I just mentioned, to think about, instead of their parents being the persons who are doing things to accommodate their world, what accommodations do they need to be able to live adult life? So what physical living arrangements and equipment, who are going to be their caregivers in the adult world if those are needed, and what does their environment need in terms of disability universal design. Folks with intellectual disabilities need a balancing of stepping up their autonomy to an adult level with the appropriate supervision for a person who has needs for decision-making supports. How do we help encourage everyone to advocate for community inclusion for this population so that they aren't isolated after leaving secondary school? How do we help them communicate about their body needs at a health literacy level that might be different than a neurotypical individual. And then the fourth category is those with serious mental illness. And the particular issues there are planning for a fluctuating course where there may be some needs for decision-making supports and where denial may have a more significant role in the person's acceptance and adherence to their own treatment. So incorporating these different pieces becomes important in the introduction of care of a person to the adult practice. Next slide, please. One other background piece of information I want to talk about is how we think about the developmental stages and the whole process of transition. These young adults who are in the 20 to 25 range are moving to the adult team, and they're exiting either special education, secondary school, or college, but they're still struggling with issues of adherence and disease acceptance and self-regulation because their brain development is still evolving. They still have prefrontal cortexes that need to myelinate more. They still are pruning their corpus callosum. Their brain isn't at full adult state. And so the 15 to 16-year-old who develops some difficulty with disease non-acceptance classically has that happen because that's the age when they have enough development in their reasoning and metacognition skills to actually look in the mirror and say, why me? Why is that happening to me? And it often is till closer to age 25 that we see youth evolving from why me to, all right, this is part of me. I get it. I'm self-regulating like an adult. So that's why we need that scaffolding from the points of transfer at 18 to 22 on up through 25. Next slide. We've already talked a little bit about how the two models of medicine are different and how the introductory plan or FAQ for adult practices needs to help young adults understand that it is different in the adult practice. Autonomy is the focus as compared to the proxy caregiver model of childhood. The scopes of practice of adult providers are different, as Dr. White already mentioned, in terms of the differences in how primary care versus specialty care interact with each other and how much the primary care office assumes versus what pieces the subspecialty practices will be doing. And understanding that difference is a critical piece for youth and family. Next slide. So let's talk now more about specifics of scaffolding and what tools you might be able to recommend folks to use in adult practices as they integrate young adults. Next slide. Most of us are used to doing something in our practices called medicine reconciliation or medication reconciliation. And this means that we teach and make sure that the patient knows all their medicines and knows when they need refills on them and are ready to take those medicines. That is only a sixth of knowing how to take care of whatever your health condition is when you stop and think about it. And you'll recognize this tool because it looks like an asthma action plan, but it really can be an inflammatory bowel disease action plan or a sickle cell disease action plan or whatever your chronic illness is. And in using this, we give this to youth for them to teach back that they understand their disease. Do they understand how their body feels when it's well and what they have to do to stay well? Do they understand what a flare of their disease would feel like? And do they understand then what they would do if they were experiencing a flare? And then next, what actually is an emergency and what should they be doing at that point of an emergency? And it's all six of these columns, if you will, or squares that are the information that a young adult needs to be able to take good care of their own needs. It isn't the sole piece of how to promote adherence. It's the first step in knowledge and understanding before we can get somebody on further down the path to adherence. Next slide. So most of you will recognize that teens and young adults often have smartphones in their hands. In fact, it's unusual for them not to have a smartphone in their hand. So we've started using recommendations for 2 different types of smartphone apps. And as a general rule at Kayak, we try to use apps that are both iPhone and Android compatible and don't cost anything. And so these are 3 examples of health habit apps to help young adults take better care of themselves regardless of their health condition. Are they sleeping enough? Are they eating healthy food? Are they drinking enough to stay hydrated? Are they working on one particular weakness and need reminders and support in doing that? So using your phone as your scaffolding support becomes an interesting idea to teenagers who like their phone closely attached to their hip. Next slide. The second set of smartphone apps that we recommend are ones that are more specific at your individualized treatment plan. So what are your medicines? Who are your doctors? When should you be taking those medicines? When do you need refills of those medicines? So here are 3, again, apps that are available for use for this kind of a remindering or scaffolding. I like them all. I guess maybe my current favorite might be CareZone, because you can actually take a picture of your medicine bottle and it then imports the information into your medicine list. And if the label on the bottle isn't very clear, it then asks you questions to clarify, but it'll be able to tell you then when you're due for a refill, and it'll ask you if you've taken your medicines and give you an opportunity to document them at the times that they should be taken. All of these are very useful to the person who is constantly attached to their smartphone and can get those reminders at the point when they need them. Next slide. Using some form of in case of emergency is also a important piece of being autonomous or a young adult. And so we train our youth to use tools on either iPhone or Android systems. There are ones that are more specific for certain health conditions, like this one for autism, that I also find fairly handy in helping to describe what a person's unique needs might be, as compared to just providing a piece of contact information for who the in case of emergency person is. Next slide. So that was a little bit about how we train youth to be in charge when they arrive at the adult office with adhering to their care plans. Now we're going to talk just a little bit about ways to track and monitor patients who might be higher risk and might need more specific attention at their integration into adult care. Many of you may be familiar with the TRAC, or the Transition Readiness Assessment Questionnaire, validated by Wood, Sawicki, Rice et al. We use it as a scoring tool to help in transition planning to create next step educational action goals for youth and young adults, but we also use it as a method of communicating in our transfer packet of information how well this youth or young adult is prepared for being the autonomous adult, self-managing their own needs. And we, based on the score that people have on their track, we divided them into 3 different groups. Those who are very nearly self-competent, and so therefore we would say we believe this youth is currently ready to navigate the adult health system. Those who are on their way but still need some extra help are getting ready to navigate the adult health system. And then maybe some youth who are not particularly strong in their self-management skills, we identify as still needing significant preparation to navigate the adult health system. And within that, we would then recommend that they have some stronger scaffolding supports set up for them because of that. Next slide. Not only do people have self-management readiness, but they certainly have a variety of social determinants of health that may or may not interfere with their ability to adhere and be their own advocates. We at Kayak use this tool that was created by Bob Nickel, a developmental pediatrician at Oregon State, and we score youth and families in these 5 domains of health, family, mental health, education, and special issues. And based on the level of stressors that an individual has, we score them as having high stress, medium stress, or low stress. And we include in our transfer document that based on a life stressor assessment, we recommend that this youth is either going to strongly need ongoing care coordination, and we're cueing the adult practice to include some tracking and monitoring or additional resources. Perhaps state Medicaid has special disability care coordination services that could be activated, or waiver case manager care coordination services, or some other means within the health system. People who are in that moderate zone, we identify as likely needing ongoing care coordination right at this time. And then there are the others who are clearly serving as their own advocates already, and the language we use is they're excellent at self-advocacy and will likely need limited ongoing supports. Next slide. In addition, what I was just talking about is the socially complex patient being received into practice. Now, this would be the medically complex patient. We are experimenting with different models of using shared plans of care on paper or integrating them into our electronic health record. And I chose to use this example as the format we're creating in our record, which is Cerner for our system, of a way for different clinicians to put the succinct needs of the person in a shared plan of care. So if their diagnosis and issue is inflammatory bowel disease, and the current goal is to maintain their weight and keep them asymptomatic in terms of abdominal symptoms, and the plan is whatever it is, and then also defining those flare and emergency symptoms and plans, like we had the young adult do previously on the action plans, and implanting this as a succinct piece of information in the medical record in a well-identified place that's not just with all of the visit notes that appear as PDFs. We're targeting it in Cerner into our care plan folder as a place to for everyone to know to look for it, is another way that we're trying to activate everybody to get on the same page and have scaffolding that works for the young adult. Next slide. So now let's talk about some of the tools that we encourage offices to use as they're receiving young adults. You already heard from Dr. White about policies and office FAQs, as well as last webinar with the receipt of a transfer packet. We're going to talk about how we go over the receipt of the packet and what other tools or handouts and resources we recommend. Next slide. We send a transfer packet a variety of different ways based on which health system we're dealing with across the state. And that adaptability has been well received by different practices. When we schedule that first appointment, we always verify that it's actually kept. So the care coordinators have a reminder to check on, either for families that are low at self-advocacy, they actually provide an additional reminder about the visit, and for families that are high, they might just check on them after the visit to make sure it went okay. We have methods of phone, fax, or email confirmation of the receipt of the packet. Email's nice when you can do it within a secure system, because then you can confirm that it was opened as well often. We are experimenting with some new secure messaging systems that can cross systems. The one we're currently experimenting with is PMD.com, and if you have practices that you distinctly are going to share with regularly, but that aren't in your own, using your own EHR platform, one of these secure messaging systems where you can send information might be another interesting alternative. Certainly, if you have patient portals that you're using, the patient having the information in their hands is another good method. And we try to give the information to the receiving office as well as the patient, so we're empowering both parties to bring that information to the visits, and hopefully increasing the percentile of times that happens by triangulating it in multiple directions. Next slide. We use tools to help convince young adults and encourage practices to use that instruct people why you want to use primary care as your medical home, as your launching pad, even if you have other chronic needs and subspecialty needs. Sometimes young adults, the National Ambulatory Care Survey would show us that young adults use urgent care in excess of their use of primary care, and so they sometimes need some information and help in getting what do you get different by using your primary care doc for this concern versus what you would get in an emergency room or from attending just a subspecialist practice. We use this activated patient tool that will be provided for you after the webinar. That is the preparation that the youth does before they go to the visit. And when you see the whole document, you'll see there's a portion that they can fill in after the visit as well to help them carry forward what they've promised to do as a result of the visit. But these are classic issues like, why am I coming to this visit? What's happened different to me since I was here last? What other providers have I seen, or what tests have I had since I was here last? What results do I have questions about? What medicines do I need? And this prep work helps a person learn what it means to be activated. Next slide. These are the tools we use and also will be provided for you that are tools to help adult providers stop and think about the difference in caring for young adults. The first one on your left is an introduction to what it is to be activated. And we talk about how we use the transition readiness tool that I've already described for you. In addition, we use the 5 A's, and you might be familiar with the 5 A's as a way to address self-management behaviors. The 5 A's are assess, advise, agree, assist, and arrange. And many health providers, adult providers are familiar with this. Many of them learn about it when they learn motivational interviewing in regards to tobacco cessation, as an example. But bringing it into working on your adherence to your treatment plan as a young adult is an important way to take something that adult providers know and move it into this young adult realm. The second handout on the right talks about more explicitly the differences in young adults' adherence issues that are somewhat different than the ones we see in older or the whole population of adults, and then gives some suggestions about ways that you can help individuals maximize their adherence or improve their adherence. Next slide. The last thing I want to talk about that we provide for adult practices to help them integrate patients into their practice is to think about what community organizations do practices know about. Many times they are aware of area agencies on aging because they're adult providers and they do geriatric work, but often they're not familiar with home and community-based waiver services through bureaus of developmental disabilities or whatever name they have in specific states. I've put the Indiana specific ones here just as examples. Many of these state agencies have slightly different names in different states, but have the same intent. Many adult providers are not familiar with centers for independent living, where persons with disabilities are providing resources for and peer support for other individuals with disabilities. Many adult providers are not familiar with parent-to-parent networks that help caregivers navigate the transition of care and transfer of care. And then, of course, other diagnosis-specific organizations, other disability support organizations in states. Most states have a University Center for Excellence in Developmental Disabilities, a disability awareness organization, and a protection and advocacy service. And all of those become important when you're serving adults with disabilities. And from a Title V perspective, I think it's important, and we've used cross collaboration with other offices at the State Department of Health, like offices of primary care. We use a lot of our community health centers and our community mental health centers around the state as receivers for the patients that we're transferring out of pediatric care. And we use our Office of Chronic Disease to work on some ideas around chronic disease management in people with intellectual disabilities or other serious disabilities. And so an active role in those cross-departmental discussions, I think, is another way that you can support improvements in the transition of care and the supports for adult providers in integrating these young adults into their practice. I think we can go to the next slide. I'll hand it back to Patience.
Great. Thank you so much, Mary. That was terrific. Now it's time for people, if you have questions, please type them in the chat component. And I know that Peggy's sitting next to me, so she has some questions to start with. So Peggy.
Thank you so much, Patience and Mary, for such a wonderful presentation. I think so much of our previous webinars have focused on the pediatric side, so it's really nice to be on top of the bridge, moving into the adult sector. Mary, my question is for you. I would imagine a lot of adult providers in Indiana who receive your youth appreciate the level of scaffolding you're providing them. I'm wondering if you have any feedback that you've received from doctors about how that makes them more interested in receiving young adults, particularly those with greater medical or social complexities.
I think that the 4 care coordinators on our team would say that we cultivate practices a variety of ways, and particularly when we're introducing new complicated patients, we provide them with chronic care handouts about diagnosis, or we provide them with specific information from the genetics home reference page for diagnoses that are so rare we don't have a handout for them. And then we also assure them or reassure them that we'll help get their back as they're starting to get used to the new patient. And so some of the ways that we do that is by filling out a prior authorization form the first time for continence supplies, and then giving them a copy of it and explaining these are the key points of what they need to fill in, and then asking them to take it over now in handoff from us, which is feels very supportive to them, and they really love that in particular. We also have spent a lot of time learning a lot about adult decision-making supports for people with neurocognitive disabilities, and the 3 docs who work at Kayak all are, I would say now, relative experts in helping to discern power of attorney and guardianship needs, as well as then completing legal documentation that's needed for those. And so that really helps the adult providers also by doing some of those added supports. And we collect physician satisfaction information from people who receive patients from us, and tend to ask them what they learned from us and if we met their needs. And as a general rule, they're very satisfied by these supports that we provide, and it's always interesting to hear the sort of things that were new to them. So specifics of how to do a better job on a disability claim, or how to think about decision-making supports comes up quite often, as well as the chronic care handouts being useful to helping them feel ready to receive. Maybe they love the medical summaries we create even more if I stop and think about the list of things they mention.
I was going to say, as an adult provider, that medical summary that's short and to the point is fantastic. I have a question here that's been typed in. It says, do you have resources, forms, tools for pediatric providers who only manage care of medically fragile patients who will always have a parent guardian meet their needs and make decisions on their behalf? So it's really questions about how do you change any of this if you have a caregiver that's really managing most of the young person's health.
In fact, in our Kayak program, we have a disproportionately high number of people with serious neurocognitive disabilities who are cared for by caregivers. We have a couple of different type tools we use there. We use a specialized hospitalization plan to help explain the unique hospitalization needs of someone who won't fit into an adult hospital easily. And let me describe what I mean by that. A person who might be under 35 kilos in weight, and therefore not the right person to give full adult dosing for codes, or a person who needs fed in a certain manner to be safe, or has certain continence related needs. We try to specifically highlight those in transfer documents and empower families to carry them and use them in the events of hospitalization. We use special tools that help describe what a person who might be nonverbal looks like when they're well versus ill, to help prepare the emergency room receiving doc to understand that this person at this moment is not well, even though he doesn't have the classic behavior of a person who's not well. We use tools for parents to help them think about the health habits that they need to monitor for a person who isn't actuated to be in charge of their own care. The example would be people who don't hydrate themselves well, or can't maintain their continence without reminders, or not maintain their own satiety and hunger cues well, and create some health habit rules for families to follow to maximize individuals' health. So those are some of the things we use for that specific neurocognitive individual.
Sounds wonderful, Mary. I have another question here about oftentimes when the young adult goes for the initial visit, we often hear as patients has talked about, you know, you want the pediatric provider to send some non-medical information so that that first initial visit, there's some like human connection. I'm wondering, from your experience working so closely with young adults and families who've made the transfer, are there particular things that are really important from their perspective that the new adult doctor does or attends to?
I have a funny story that demonstrates this best. We had we did simulated patients exercises to train some of the medicine residents, and we actually had individuals from our local Down syndrome adult organization be the patients in this simulation. And one of the important cues that the young adults with Down syndrome taught the internal medicine residents was how to just learn to make small talk and say, I love the color of your shirt. Gee, is that your favorite team that's on your shirt? And it's fascinating how the business of internal medicine is not classically folksy like that, but the average young adult wants some, and maybe folksy isn't the right word, but personally attentive and not medicinal, and so we've learned to teach that to receiving docs, that you don't really need it in the transfer information, you just need to talk to them like they're a young adult and say, gee, I love the color of your shirt, or whatever else it might be.
Sweet.
That's great. I have two things here. First one is the tools you were talking about for the individual under a care of another. I think there were 3 of them: the hospital plan, how to recognize when they're well, and the health habits. They're asking, can they be shared?
Yeah, the DISDAT tool is online, DISDAT, from a hospice in Oxford, and I can give that, I can provide that link. The hospitalization plan is our own developed, so we can share that. And what was the third one? Because I already don't remember.
Something about health.
Oh, health habits. Yeah, the health habits tools. Yeah, we have those too.
So if you'd send them to us, we'll just put them up with the other tools. That would be great, Mary. Really appreciate it. I have a quick question. Have you ever, when you're, it's in the vein again of somebody who's really taking care completely of another person, do they ever use phone apps to help them to remind themselves about what they need to do in this complex setting?
We rarely differentiate whether it's going to be the youth or the family doing it. We actually use a track for the adult caregiver to figure out if they are good at self-managing. And then in the transfer of care, we'll use that same coding of they're an advocate, they're engaged, or they're in need to help describe the caregiver unit, because some caregiver units are fabulous advocates and some need help, just like some youth in transfer are fabulous self-advocates or need help. And so we actually use many of the same tools in transfer that help the receiver get that same message about the caregiver unit. And so we kind of, we assess and decide who's going to be in charge. Is it going to be the kid and the parent, or the parent, and then plan what we transfer based on that, the language of what we transfer.
Great, thank you.
Mary, I have another question. you offer your Kayak services statewide. Is there outreach that you do to inform pediatric and adult practices about your capabilities?
We're here for 10 years now, so we're not needing to do a lot of advertising at the moment, quite honestly. We follow about 2,000 kids and are pretty maxed out with that. So while there are more than 2,000 kids who could use our help, we have to be realistic. We do use continuing medical education activities in both the internal medicine and pediatric worlds as ways to both do provider education and I guess it's marketing or awareness activation.
Mm-hmm. Great.
So we have an annual statewide AP meeting. We have an annual statewide ACP meeting. We use those as opportunities for discussions more than recruitment.
Great, thank you.
Great, thank you very much. We don't have any, we have obviously got some, oh, I've got, can you review again for your clinic, after the initial 90 to 120 minute appointment, how often do you provide routine care? So how long do you provide routine care?
We don't provide routine care ever. We're a consult service. So when we see someone initially, their ability to take the information we give them and move forward is determines when we're going to see them back, as well as some key points of critical transition issues. So let me give you both points. If people are high self-advocates and really able to manage and have demonstrated a history of being able to manage their own needs as a family unit, we might provide everybody with all the information they're going to need for the next 4 years and say, call us if you need us. If they're an engaged group who are good at doing things but sometimes stumble and fall, we might check in with them again in 6 months and a year or other targeted ways. And if they're a family that's clearly in need, when we assess them, we might do much more hand-over-hand supports to help them navigate their transition goals. We know that at the critical points of when you're leaving high school, when you're leaving special education and college, more check-in is helpful. We do check-ins 2 ways, by phone and or by repeat face-to-face visits. So the care coordinators do lots of their work by phone, email, fax, but we also do some follow-up visits for people who either are having a gap in their care and we have to fill in that gap for some reason, or have a critical life event. A loss of a caregiver might be another one that isn't predictable, but when it happens, it often means you need the help of the care coordination team to reorganize things again.
Well, great. Thank you so much, Mary. You obviously gave people wonderful information and things to think about. I also want to thank Shirley Payne for coming on and giving you that wonderful introduction. And this is going to be the end of this webinar, but I wanted to remind you that the last of the 5 care coordination webinars will happen on June 28th, 3 to 4 p.m. In the afternoon Eastern Standard Time. It's going to be about youth, young adult, and parent engagement. Thank you again, everybody, for attending.